to talk to you kind of quickly about national perspectives and continuing medical education for pain. And I want to talk about policy. How does national policy impact continuing medical education? I want to clarify right now, continuing medical education is not just physician education. I think that we need to make it a group effort. We need to understand the work I do with RSDSA is continuing medical education, and we have got to get out of the idea that we only need to educate clinicians. Okay? One of the things that I feel passionate about, and you'll probably pick up on that today, is we're not educating enough people and we're not educating the right people. I do want to talk about the impact of the IOM report on pain management, and I want to talk a little bit about what are our barriers to good pain management and how we can overcome them. And that's a little bit optimistic, but just what I see. Policy and education anymore in this environment, the policy is the guys who sit in the big offices and say, you know, here's what needs to happen, and somebody picks up the call and says, education has to do it. Okay, we're the army that has to take these good ideas and find a way to make them work. So, what's happening today, everybody knows this, the dual problem of undertreatment of pain and opioid misuse, abuse, addiction, and accidental overdose. What's happening is it's all getting thrown into one great big pot and saying, fix it. All right? What I'd hope to have today, and I will definitely have for you tomorrow, is a copy of the fall issue of the Pain Practitioner magazine. It's the American Academy of Pain Management magazine, which I have the honor to edit. And I have it here for 3 reasons. One is it has a really nice cover shot of glial cells by Mike Daly. It has a nice interview that I did with Mark Cooper, so if there's any of you who don't really understand why we're here and what you're doing, that will explain it all to you. But the best reason is there's a great article by Bob Twillman, who is the Director of Advocacy and Policy for the Academy, who's basically saying we don't have a balanced pain management policy in America. We have controlled substance policies. They get intermingled and messed up, and so what's happening is nothing good is happening. So he says, it seems as though the vast majority of pain policy work at present is driven by concerns with the misuse, abuse, and diversion of prescription opioids, often to the detriment of people with pain and those who provide care for them. That's the piece we need to focus on. Look at I don't know if you guys are familiar with the opioids, FDA and the REMS education requirement for prescribers for long-acting and extended-release opioids. This has been going on, debated for 2 years on what kind of education needs to happen so that prescribers can prescribe these medications. In addition, states like Florida is demanding 40 hours of live CME on prescribing in order to keep your ability to prescribe. 40 hours of CME is a lot of hours of CME. You've got Florida, you've got Ohio coming up with same kinds of criteria, Washington State. But it's not going to work. When you say, will mandated education for clinicians solve the abuse problem? Well, probably not, because 77% of 18 to 25-year-olds get painkillers from non-medical sources. 52% of the 50-age plus group get painkillers from non-medical sources. Less than 3% of painkiller addicts initially become addicted from their medical prescription for legitimate pain. So what happens to people like me who do education is they hand you a problem and they say, here's the problem, here's the solution, we want you to do it, and we know it's not going to work. That's the kind of policy that we're dealing with that makes my life crazy. You know, I can't tell you how much money is going to go into this program. It's probably the gross national product of Uganda. At the end of the day, we're not going to solve anything. That's where policy fails us in pain management. Again, we're talking about addiction. We're not talking about pain management. I think if we want to succeed in this, we have to educate all of the stakeholders. We have to take that message to patients. We have to have, I think, a hard-hitting message that says, if you take this medication, you could die. If you take this medication, you are breaking the law. You know, we really, I don't know why we hold back on this. We need to tell our patients, lock it up. Lock it up. If this makes it out onto the street, somebody is going to die. We're not educating strongly enough where the problem is happening. I think that we need to educate policymakers. We need to educate the people who are passing these laws. Personally, I would love to say, you can't vote on that bill because you don't have 20 hours of good CME to show you know what you're talking about. I'm there. I think we should do this. Same thing with the people who determine what we're going to pay for. We don't educate them, but we really need to get into the public and say, look, the problem is the people who are using them inappropriately. Maybe we need to start arresting the kids. But to spend millions of dollars on education for clinicians who don't need it at that level, I think is a shame. I also think that if we're going to start looking at a balanced pain management policy, we can start with the IOM report. And, there was nothing in the report that was new to most of us. I think the fact is we all know pain education, pain management is not working in this country. And if we've gone from, when I first started doing this 10 years ago, there were 50 million people in America that suffered chronic pain. Then there were 75 up until a couple years ago, and now we've hit the 100 million mark. Whatever we're doing, it's not working. And I think that we need to look at that and say, what do we need to be doing that's a little bit different? So from the IOM report, they admit pain is a major public health problem that needs to be addressed on multiple levels, and I agree with that absolutely. And that optimal care requires an interdisciplinary biopsychosocial approach, and I think that's been proven over and over again. And I like it when they say remediating the mismatch between current knowledge and its application will require a cultural transformation in the way clinicians and the public view pain and its treatment, identifying and ultimately removing barriers to care on the system, the clinician, and the patient level. Okay. Yeah, how? Where do you want to start? You want to start the clinician, the barriers on the system, the clinician, or the patient. They're huge. It's in a report that makes it sound like it's something that we're just going to go home and figure out how to do, and the fact is, it's not that easy. And they also said in the report, government agencies, healthcare providers, healthcare professional associations, educators, public and private funders of healthcare should take the lead in this transformation. All right, look around the room. Who do we have here? We have government agencies, we have healthcare providers, healthcare associations. I don't know if we have any funders, but the fact is, this is us. This is not them. This is us. And the people that are going to do this has to be us, and we have got to figure out how we're going to do it. And I think that that their method of improving care really leads to what we consider an integrative model. They should tailor pain care to each person's experience. We know that people don't react to the same therapies, the same way of being talked to about pain. We think we need to promote self-management of pain, and I think this is something that needs to be done so much better. We need to let patients know what they can do to manage their care. We need to let them take as active role as they can, and we need to educate them better and more. I think that primary care physicians should collaborate with pain specialists absolutely and whenever they can. Right now, pain management is still being handled 90% by primary care docs. These are the people that we really need to form good collaborations with and good education with. And I think that when you talk about insurers, this is where it gets really muddy. What kind of incentives do they want to offer? That they want to offer incentives to support the delivery by primary care providers of coordinated, evidence-based, interdisciplinary pain assessment and care for people with complex pain. Okay, but how and who and when? And I think that, again, they want us to produce educational materials. They want us to talk about the nature of pain and to help people understand what they're going through. And again, self-help strategies. How can we help people reduce their stress? Can we help them? Can we teach them about nutrition? Can we teach them about exercise? How do these things impact their pain? And I had a friend, who was an integrative clinician who said, if everybody in America practiced better stress management and better nutrition and exercised better, we'd all be healthier to start with. We'd all feel better. So why do we not carry that message over when we talk to people in pain? It's almost like we're afraid that if we say wellness matters, that it's like, well, wellness isn't medical. Wellness is somebody else's problem. I think we need to look at wellness. We need to educate why wellness matters. And again, the materials should be specifically targeted to patients, the public, and healthcare providers. Again, we need to educate everybody. And we need to educate them with a consistent message about what their options are. And I think that it is about options. So back to my pal Bob Twillman, who said, again, we need to return our focus to policies that promote the provision of good integrative pain care, the type of care that utilizes controlled substances where they are appropriate, but doesn't see them as the only treatment or even as the centerpiece of treatment. Integrative pain care considers the whole person and designs interventions that are comprehensive and that address multiple aspects of an individual's experience as a way not only of relieving pain, but increasing wellness. We need to change our outcomes. We need to talk about restoration of function. We need to talk about, you're not going to eliminate your pain, but maybe we can give you a life. There's so much exciting stuff going on about how the brain impacts pain, how you perceive pain, how you perceive suffering. And I think that the barriers to care, regulatory, legal, institutional, financial, and geographic, it limits the availability of pain care and it contributes to the disparities found among some groups. I think, like the Project ECHO program. I will tell you, I'm in love with that program. I've participated in 4 of the clinics, and I think it's brilliant, and it so beautifully serves, an underserved population. And, when you talk about a PA that's in rural New Mexico who has no idea of pain management, and all of a sudden the people that she's seeing have complex pain issues, it's a godsend. It's a life-saving program. And I think it's something that we should look to see, how can we make it work? Reducing barriers. But, it comes down to money. No matter what you talk, all of the barriers, everything about this comes down to money. We need funding for educational programs. We need funding for patient and caregiver materials. Clinicians getting paid to do integrative pain management is a lot more complicated than other models. And again, I'm back to lack of education among policy makers and payers. And if they don't understand it, how can you vote on it? How can you determine what good care is if you really don't understand what the problems are and what better options are? Oh yeah, getting paid. Yeah, so back to the IOM report. And they say even for people with insurance coverage, third-party reimbursement systems tend not to cover or cover well psychosocial services, et cetera, et cetera, et cetera. But they say surmounting this barrier may require coordinated action by advocates for improvement. I think advocates for improvement is a feckless term. Okay, what is an advocate? We're all advocates for improvement. It's like, I don't really know what they want to tell us to do, but we're going to be advocates for improvement. And I'm in. I want improvement, and I will advocate for it. We just need to figure out how we can do it and what makes sense. So rather than say, let's change the insurance industry, let's change everybody, it's like, who's the one person that we all know that we can change? Who can we as individuals change? Who can we make a difference? Because we can't, if you say, I want to change the insurance industry, you might as well go home. You want to change Congress? Yeah, that's going to happen in my lifetime. We have to look at the big systems that need to be changed and figure out, as organizations, as individuals, who is that one person that maybe we can change their thinking just a little bit? And I think that we have to look at who benefits from people getting better. So much about pain management is not about people getting better, and I think we need to look at that. So who cares? Other than your friends and family and whether you get better. And I think that there's a brilliant clinician in Springfield, Missouri named Lance Luria, and he is in charge of their integrative program. He's also in charge of their insurance program. He's doing some great research that shows very simply that if you take a series of pain patients who were scheduled for like spinal cord stimulators. And you give them the option of running through a good integrative program that incorporates exercise, nutrition, stress reduction, medication, that by and large, I think out of a cohort of 46, only 2 opted at the end of the day for a spinal cord stimulator. He ended up saving a couple of $1 million for an insurance company, and people got back to work. We're looking at people who can get this data, that can show us why this matters and how it can work. He also said, in addition, that we should be talking to large employers. Who are the people that want these people back to work? And finally, we should be looking at the military. Because who better, than the military for getting people back to work? And I think if any of you, I don't know if you're familiar with the Department of Defense Task Force report that was released about 1.5 years ago. They had 100 recommendations on pain management. And basically, their recommendations, they want an integrative program. Their recommendations say the tools should lead to a comprehensive pain management strategy that is holistic, interdisciplinary, and multimodal in its approach, uses state-of-the-art science modality and technologies, and provides optimal quality of life. This is a big system that is buying into this philosophy, and I think we should pay attention. So the fact is, we come back down to this. It's like, all right, we know it's the right thing to do. We know it's the right thing to do. And where are we going to get the funds to do this? And I'll tell you, it beats the hell out of me. But what I want you to consider, because that's a large thing, I want you to look at who you are with today and where you are today. And I'm going to tell you, the RSDSA has put together this program. We have built a program over the next 2.5 days that, in terms of funding, costs less than a 1-hour symposium at the American Pain Society. It costs less than an hour symposium at the American Academy of Pain Medicine and probably at the American Academy of Pain Management. If we use our money wisely, we can do great things. I'm also going to tell you, speaking from the RSDSA, any program you ever attend for the RSDSA was initially funded by some kid selling a cupcake. Shop Till You Drop fundraiser in Nyack, New York. This organization was built by parents who had two mothers who had daughters who had RSD. They started funding research in 1984 with bake sales. They sold dolls. If you look through the RSDSA review, you're going to find every month somebody is doing something to raise money to make life better. And I think you can look around this room and you can see an enormous amount of brain power. I don't think you can find better brain power. But I also want you to recognize in this room there is enormous heart. And without heart, the brain power is not going to go anywhere. It absolutely is not. You have these little kids. I don't think I have any more. Oh, here's a team of 5th graders who had a teammate, a classmate who had CRPS. Well, let's have a catch-a-thon. So they organize these little events. They raise money for us. Consider today your lunch was probably raised by money that kids raised to make life better. So what I want to leave you with, other than I should leave you with that shot. That is great. I want to leave you with, we have tremendous opportunities and tremendous challenges. And the fact is, it's not just going to happen. We're not going to get a huge grant from the NIH, and we're probably not going to get a huge grant from pharma, and we're probably not going to get huge foundation money. But what we can do, each one of us, what can I do to make a difference? Look at this workshop again today. This was not motivated by science. This workshop today was put together because two kids with RSD have fathers who could make this happen. Mobilize the community, mobilize yourself, because it's up to us to make a difference. Continuing medical education crosses all areas. We have got to get everybody involved. We've got to start taking a step, and we've got to move forward. We've got to stop looking at pain as a battle. We've got to stop using terminology like war against pain and conquering pain and shooting pain, because there's no winning or losing. There's just moving. This is a journey, and we're all on it together. And while we're here this weekend, talk to me, talk to each other, tell us how you're going to start. Give us an idea or give us $1. Thank you very much.